And we shall now go on to our next speaker, Dr. MAHESH Shanmugam, who heads the Vitreoretina and Ocular Oncology Services at Shankara Eye Hospitals, an extremely innovative, brilliant individual, and is also presently the Chairman Scientific Committee of ARSI. And I'm sure he's going to lead this society way forward in his term. And he is going to be talking on angiographic patterns in intraocular tumors. On to you, and the discussant here is Dr. Guru Prasad. On to you, Dr. Mahesh.
Thank you, Dr. Chitra, and thank you, Dr. Chitra and Srinivas for inviting me to this wonderful session. So let's look at the angiographic patterns in intraocular tumors. So as in any other investigation, angiography is useful, but then it's not diagnostic as far as tumors are concerned. It may help differentiate one tumor from the other. And it's particularly useful in vascular tumors. And as I mentioned, it's not diagnostic. In retinal tumors, you would do an FFA. ICG may not play much of a role, but in choroidal tumors, FFA and an ICG can play a role. OCTA can be used in both, but the issue is that it needs manual segmentation, as we will see subsequently. So let's start with the retinal vascular tumors. Retinal capillary hemangioblastoma, it's a clinical diagnosis. We will see this dilated retinal arteriole and the draining dilated venule, and a vascular tumor in between, which is orange-red in color. And if you were to do a fundus fluorescent angiogram, this tumor fills very rapidly along with the arteriole. And because of a very high flow system, it kind of fills in very rapidly. The capillaries fill in rapidly, and profuse leakage is what you would see. So clinical diagnosis, what you would see as far as the capillary hemangioblastoma, retinoblastoma, capillary hemangioblastoma is concerned. But then what is the use of a fundus fluorescent angiogram? The advantage of a fundus fluorescent angiogram is it shows up these tiny new lesions which may not be picked up on clinical examination. Particularly in von Hippel-Lindau, the earlier you treat the disease, better is the outcome. So we pick up these small tumors and treat them at the earliest, then these eyes are likely to do well, but otherwise these eyes may be lost as the tumors continue to increase in size. So let's move on to the OCTA. Yes, OCTA can be done, and it shows the beautiful capillary network within the tumor. But the thing is, it doesn't show leakage. It's one way a good thing, because the vascularity within the tumor is seen quite well. And we can see the presence of the feeder arteriole and the draining venule. And once again, you can use the OCTA to pick up these very subtle tumors which are not obvious in clinical examination. Here we see a fundus photograph. You can see one lesion here, but this lesion here is not visible. But then when we do a OCTA, it is picked up quite easily. But what is the limitation? The white field OCTA is not freely available with most of us. And when the white field OCTA is freely available, then we can replace the fundus fluorescent angiogram with white field OCTA to pick up these very, very tiny tumors in von Hippel-Lindau disease so that we can treat them early. Here is one patient where there looks like a disc edema, and we are not very sure of the diagnosis. And we did an OCTA here, and you can see that there is a retinal feeder vessel here and a compact vascularity. So what we're seeing here is an endophytic juxtapapilar retinal capillary hemangioblastoma. So you can make a diagnosis just based on the OCTA here. Let's move on to another retinal tumor. This is a cavernous hemangioma. Cavernous hemangioma is like grape-like cluster of sacules which have a sluggish flow within. So what happens is the RBCs and the other white blood cells settle down within the sacules. That's what we see here, the dark red color. And the upper part is just plasma. And so when we do a fluorescent angiogram, this plasma alone fills, giving rise to this beautiful fluorescent caps. So these fluorescent caps are very, very diagnostic as far as cavernous hemangioma. And this kind of helps us diagnose in subtle cases, as in this case. This lady presented with a vitreous hemorrhage and a pre-retinal hemorrhage overlying the disc, and we could not see the underlying tumor. But when the hemorrhage cleared and when we did a fundus fluorescent angiogram, you can see these beautiful fluorescent caps, and this patient was treated with photodynamic therapy subsequently. Yet another vascular tumor involving the retina is a vasoproliferative tumor. This once again has vessels which are feeding a yellow-white tumor, usually situated in the inferior periphery. The vessels are not too dilated, but you can see the extensive exudation. And they do leak profusely, and a fundus fluorescent angiogram can help pick up these lesions as well. Retinoblastoma is another tumor where very rarely we can do a fundus fluorescent angiogram. The issue is because these are being children, you need a specialized equipment like the RETCAM, which is capable of doing a fundus fluorescent angiography. And fundus fluorescent angiogram is not necessary for diagnosis or for treatment, but in subtle cases where there is recurrences along the scar, then this can be picked up by doing a fundus fluorescein angiogram, which can show up these areas as a vascular lesion, and an early recurrence of at the edge of a scar can be picked up by doing the fundus fluorescein angiogram. And here we see a lesion which mimics retinoblastoma, but it's actually an astrocytic hamartoma. It is an OCTA, which shows there is no vascularity within. And similarly, the fundus fluorescein angiogram also does not show vascularity. So you can do FFA to differentiate retinoblastoma from an astrocytic hamartoma. Let's move on to choroidal tumors. This is a solitary choroidal hemangioma. Because it's connected to the choroidal circulation, it fills very rapidly in the choroidal space itself, and it's a vascular tumor, so it tends to leak profusely as well. So early hyperfluorescence, which increases in intensity, and pooling of the dye when there is a retinal detachment and leakage is what we see. ICG is very characteristic as far as choroidal hemangioma is concerned. So it fills within the first 1 minute here, and the hypocynosins, what happens is like the dye tends to wash off because ICG is bound to the proteins. So it doesn't stay there, it tends to wash off. So at 20 minutes, the dye tends to wash off. So that's very classic of a choroidal hemangioma, which doesn't happen in a choroidal melanoma. So OCTA also shows up this network and shows that the network of the tumor is distinct from the surrounding choroidal vasculature. And here we see 3 different tumors, and we picked up this OCTA to be useful in kind of predicting which tumor is likely to leak and which tumor may not leak. You can see these black areas. You see the signal void areas. When the signal void areas are more, then these tumors probably do not leak much. So that's what we found. So OCTA can be used to predict which tumor is going to leak and which you would probably want to treat. So here is a patient who has probably a normal looking fundus, almost normal looking fundus, but then the right side, there's a patient Port-Weinstein. And you see the OCTA, you can see the beautiful network of bag of worms like appearance, which is distinct from the other choroidal vessels, thereby helping us make a diagnosis of a diffuse choroidal hemangioma. Moving on to choroidal melanoma, there is nothing specific about choroidal melanoma except for the fact that sometimes may show what we call as a double circulation. Double circulation is the simultaneous filling of the overlying retinal vessels, and the underlying tumor feeder vessels is called as the double circulation. Once again, the dye fills in very rapidly because it's connected to the choroidal circulation. But because of the lot of pigment in the tumor, lot of the dye is masked. So you would hardly see much of a fluorescein except for this spotty areas of fluorescein, which do leak in the late phase. And ICG, once again, shows that you can see the beautiful double circulation. You can see the choroidal vessel supplying the tumor out here, and tends to leak a little bit, but much less leakage than what you would see in a hemangioma. So you can do OCTA in these elevated tumors. The problem is when you do a machine-aided OCTA, this is how you'll get these images, because the machine tends not to look at the elevation of the tumor, so it's not able to segment and give us a beautiful picture of the vascularity of the tumor. But on the other hand, if you sit and modify the OCTA and manually segment, you can get these beautiful images. So elevated tumors like a melanoma, if you were to sit and segment them individually, then you can get much more information of the tumor vascularity. So here is one patient which has an elevated lesion here and another pigmented lesion which possibly looks like a melanoma. But if you were to do OCTA, you can see that this is vascularized. There is vascular network within. So this is actually a juxtapapillary melanoma. Here there's no vasculature at all, which is essentially a melanocytoma of the optic disc. So another utility of OCTA is to help differentiate between melanoma and the nevus. You can see this is a melanoma. So melanoma has an ill-defined margin. In contrast, nevus has a sharply defined margin. And there is a hyporeflective choriocapillaries in melanoma, and the avascular areas are more in the melanoma, and choroidal vascular changes are also there in the melanoma. So any nevus which is converting to a melanoma, you can differentiate by using the OCTA. Here is a 40-year-old lady who was referred as a melanoma, and you can see this spotty hyperfluorescence, which looks very much like that of a melanoma. But then if you look at the disc, you can see a hot disc. So what you're looking at is not a melanoma, but an inflammatory pathology, which is essentially posterior scleritis, and you can see patient resolved after steroid therapy. Choroidal lymphoma, you can see the speckled hyperfluorescence, and if there is a vasculitis in a primary intraocular lymphoma, you can see a hot disc and vascular changes. But there's nothing peculiar about a choroidal lymphoma FFA. Osteoma, yes, a simple osteoma as such can show this pinpoint hyperfluorescence, but with minimal leak. But the utility of FFA is the identification of the choroidal neovascular membrane in an osteoma. And OCTA, yes, does do a great job of identifying these choroidal neovascular membranes associated with the osteoma, as you can see here. To summarize, angiography in tumors is not necessary for diagnosis, but then it may help differentiate a couple of tumors. And in retinal tumors, fluorescein angiogram OCTA can identify small tumors missed on clinical examination, particularly vascular tumors of the retina. It helps confirm the diagnosis. Choroidal tumors, it identifies complications such as choroidal neovascular membrane in the choroidal osteoma, and it can aid differentiate hemangioma from a melanoma, nevus from a melanoma, and neoplastic from an inflammatory pathology. Thank you very much.
Thanks again, Dr. Mahesh. That was a wonderful talk, like hearing a story about tumors. And on to you, Doctor.
Thank you, Dr. Mahesh. It was a treat to hear, as always. And there's nothing to discuss in this. Once you have said everything, I think there's nothing that can be added by anybody. However, for the purpose of discussion and for the benefit of audience, I think we will just generate some discussion about this. You did mention about the role of angiography in the retinal capillary hemangioblastoma or hemangiomas. And you said that OCTA also is helpful, but at the moment, I think with the limitations that we have in OCTA, that we don't have the wide field OCTA, I think it is better to go with fluorescein angiogram to pick up these small lesions that you mentioned, which are useful to be diagnosed on an angiogram for the purpose of treatment at an early stage. And I want to know whether would you really like to treat these small lesions at that stage itself, or would you like to wait for them to become more obvious and treat them later? Because the bigger tumors are anyway quite obvious and overt, and we can treat them. The smaller tumors, can we wait for them to become overt in the absence of, if you don't want to do an angiogram?
We prefer to, thank you, Dr. Guruprasad, and thank you, Dr. Chitra, for the kind words. I prefer to treat these tumors as small as, at the earliest stage itself, because VHL, over the years, I found that VHL to be one of the most blinding diseases. So VHL can make the young patient blind in both the eyes very, very soon. So this may be the better eye. So I would prefer to treat the tumors when it can be treated with a simple laser photocoagulation. Once it becomes about 2 disc diameters, even the field of vision treatment becomes difficult. And we have this vitreoretinal form of the angioma where the vitreous tends to stick to it and then starts to pull the tumor up. So that causes a retinal detachment and becomes very difficult to manage. So those tumors are very difficult to do laser also. So when it is on the surface of the retina, when it is small, when we can directly laser photocoagulate, so that is why I would prefer to treat them, particularly in the VHL tumor.
Okay. Thank you, Dr. Mahesh. About the disc tumor that you mentioned, the example of a disc tumor, which actually turned out to be some vascular tumor at the disc. Is it possible to distinguish between tumor, a real tumor, and just telangiectatic vessels because of disc edema? On the OCTA.
Yeah. OCTA, as I mentioned, once it is a little bit lifted, then we need to do some amount of manual segmentation. Otherwise, there is a possibility of losing the information. And these are usually lifted. The peripapillary hemangioblastomas are usually lifted in contrast to only the vessels which are not lifted. So there'll be some amount of elevation, and it's not a disc edema in the sense like the whole margin of the disc is not elevated, only one part is elevated. So that gives us a clue. And most of the time, it can be associated with the peripapillary exudation. It could be hard exudates, which make us look at it much more carefully, and subretinal fluid. So it is possible, the fact that it is elevated, and also the fact that the network is different. You can see a feeder vessel also. So that helps us differentiate.
Srinivas, you have anything to add?
Sir, a very nice talk as usual. So one thing is, when it comes to the von Hippel-Lindau disease, according to the Cambridge protocol for the screening of the patients, they have very nicely mentioned that the frequency of tumor is usually at the age around 25 to 60%. And these are the tumors as such where we get the first most common presentation is in the eye, as compared to the spinal cord or the brain stem or the cerebellar or the pancreas or various other organs. So they also advise, yearly annual screening for FFA. And as you showed those beautiful pictures where you can just identify even the smallest lesions. So how practical is it to do annually in India? Because they say that anywhere from 10 years to 60 years. So, or should we wait for it to clinically get it, or how do you do the screening part in these cases, sir?
Yeah, practically speaking, now what I do is if there's a family history, yes, of course, they come across, and most of the time, To make a diagnosis of VHL, you don't really need to do an FFA because you can do a genetic analysis right now. So with the genetic analysis and a chromosome 3, most of the time you can make a diagnosis of VHL, particularly if there's a family history. So that's what I would resort to first rather than doing an FFA every time. But the FFA would help us identify the tumors and treat. So to make a diagnosis of VHL, I would not be doing FFA in the current scenario.
Okay. Last point, Anand sir.
Yeah, just a smaller, again, a wonderful presentation, Dr. Mahesh. Always a pleasure to listen to you. One little experience I'd like to share where I found FFA ICG especially useful. Like you mentioned, it's only angiography is probably useful only about half the time in tumors. Is in amelanotic melanomas, where I found that a couple of cases that I saw some time back had corkscrew vessels on the ICG. And this is one thing which I found, is great in diagnosing this. And it's also more importantly useful in differentiating it from metastasis, which that also could appear. So that's just a little point that I'd just like to share. And if you have any experiences with that.
Yeah, thanks, Dr. Anand. I agree to that. And I like the metastasis on, if you were to do an ICG, will not have vasculature within. But in contrast, as you said, very rightly said, the melanoma does have vessels. Actually, the melanoma vascularity has a prognostic value also. I didn't go into it because I want to keep it basic for the postgraduates. So the vascular patterns have a prognostic potential as well. So that also can be studied. And like even on the OCTA, if you segment it properly, we can get to see these vascular patterns as well.
Thank you very much, Doctor. So do stay on with us for more interesting discussions way forward.